Welcome to Dermatology Explained. Today's video series is focusing on autoimmune bullous diseases. Part 1, Classification and Approach. What are blistering diseases or disorders? These are disorders which are characterized by fluid-filled skin lesions. Vesicles are fluid-filled skin lesions less than 5 millimeters in size, whereas bullae are fluid-filled skin lesions greater than 5 millimeters in size. The bullae roof may break, leaving an erosion or crust. In blistering skin disorders, there may be an eruption of bullae and vesicles, and this can make the patient quite ill, susceptible to fluid shifts and infections and long-term sequelae such as scarring. Here are some examples of blistering disorders. On the left-hand side, we can see a diffuse bullous eruption characteristic of bullous pemphigoid. On the right-hand side, we see also another type of blistering eruption, which is characterized more by ruptured blisters, erosions, and crusting. This is pemphigus foliaceus. In this video series, we hope to elucidate how to approach and how to make a diagnosis of various different blistering disorders. First of all, in order to tackle our approach, we need to have an understanding of how blisters form. And I'd like to use an analogy of a brick wall. If we consider our skin layer to be essentially a wall of bricks, where each brick represents a skin cell called keratinocyte, and these keratinocytes are glued together by mortar, just like how bricks are glued together by mortar. And the mortar, in the case of skin, are different proteins which allow the keratinocytes to be bound together. Some examples of these proteins include desmosomes and hemidesmosomes. And when there is an issue with these binding proteins, such as when there is an autoimmune antibody binding to them, or whether there's a dysfunction or mutation in these binding proteins, then that leads to separation of the skin cells, the skin keratinocytes, and that can lead to disorders such as blistering conditions. And in terms of how blisters forms, the first way is spongiosis, and the other ways include acantholysis, reticular degeneration, cytolysis, and basement membrane zone disruption. Spongiosis is where fluid builds up between the keratinocytes, and this is characteristic of eczema. Acantholysis is when there is loss of contact between the keratinocytes, such as due to an autoimmune antibody binding to the desmosomes, and this is characteristic of pemphigus. Reticular degeneration is characterized by intracellular fluid buildup in the keratinocytes, which then blows up like a balloon and then eventually ruptures. And this is characteristically seen in viral cutaneous eruptions associated with blisters. Cytolysis and necrosis can occur in drug-induced blistering eruptions, including Stevens-Johnson syndrome, TEN, and Erythema multiforme. And finally, there's another form of blistering formation via basement membrane zone disruption. And this is characteristic of pemphigoid, where there are antibodies, autoimmune antibodies, which bind to and disrupt the proteins that hold the basement membrane zone together. So how do we approach a diagnosis of a blistering disorder? I like to think of the approach by answering 4 key questions. The first question is understanding what is the etiology and cause of the blistering disorder, what is the level of the split in the skin, what is the pattern of the lesions, and what is the patterns of the cells under the microscope in terms of the histology. If we're able to answer these 4 questions, we will have typically sufficient information to narrow down the diagnosis to 1 or 2 key differentials for a particular blistering disorder presentation. Let's go through how do we use these 4 questions. First of all is, what is the underlying etiology and cause of the blistering disorder? There are many different causes to consider in our differential diagnosis, as not all blistering diseases is due to autoimmune blistering disorders. Although autoimmune blistering disorders is often the focus of our teaching and the focus in our textbooks, we also need to consider other differentials which can also present with a blistering disorder. And this includes pathologies that are infectious, genetic or inherited, inflammatory, metabolic, drug-associated or drug-related, as well as infiltrative disorders. Let's go through some examples of key differentials within each etiology or cause of blistering eruptions. The first one is autoimmune or immunobullous disorders. These can include a variety of different types of autoimmune blistering disorders, some that we have already mentioned, including bullous pemphigoid, as we can see here, pemphigus and its variants, so that includes pemphigus vulgaris, pemphigus foliaceus, IgA pemphigus, pemphigus erythematosus, so on and so forth. There are also a number of other subepidermal immune-mediated disorders. We've already mentioned bullous pemphigoid. Other examples include mucous membrane pemphigoid, linear IgA bullous dermatoses, epidermolysis bullosa acquisita, herpes gestationis, as well as dermatitis herpetiformis. In this video series on autoimmune bullous dermatoses, we will explore each of these differential diagnoses. Here are some further imaging examples of different autoimmune blistering disorders. Notice how even though they all can involve bullae or ruptured bullae, their distribution, morphology are different, and this helps us to narrow the diagnosis. Next group to consider are the infectious causes of bullous disorders. Some examples include bullous impetigo, staphylococcal scalded skin syndrome, viral eruptions including varicella, herpes zoster, herpes simplex, as well as hand, foot, and mouth disease. Notice how the bullous eruption form of these viral conditions can often mimic autoimmune blistering disorders. So it is important to keep a wide differential diagnosis in your mind when working up an initial presentation of a blistering disorder. There are also a number of inherited or genetic causes of blistering disorders. These include epidermolysis bullosa, epidermolytic ichthyosis, incontinentia pigmenti, and lipoid proteinosis. In these cases, the clinical history as well as the family history are very important in terms of narrowing the diagnosis. There are also a number of inflammatory dermatoses which are associated with a bullous or blistering eruption, and these include Pomflox, id eruptions, an acute dermatitis, and in a younger population such as pediatrics, Erythema toxicum neonatorum is a differential diagnosis alongside with transient neonatal pustular melanosis and miliaria. Metabolic causes of bullous eruptions are quite rare. However, every now and then you may come across these cases, and therefore it is important to keep these differentials in your mind when working up a case with a bullous or blistering eruption. The prototype metabolic cause of a bullous eruption includes porphyria cutanea tarda. These often present with mechanical related blisters, particularly on the dorsum of the hands. Diabetic bullae is seen in the diabetic population and is another cause of a bullae or multiple bullae. Coma blisters and edema blisters are other differentials to keep in mind. In terms of drug-induced bullous or blistering conditions, these include erythema multiforme, Stevens-Johnson syndrome, or toxic epidermal necrolysis, as well as bullous fixed drug eruption. In these instances, it's important to look for the classic morphology, which may help point you towards one of these diagnoses, such as targetoid or atypical targetoid lesions. The biopsy result and histology will also be informative. So that answers the first question of our approach to diagnosis in terms of the different underlying mechanisms and differentials to consider. The next question to address is the level of the split in the skin. What do I mean by the level of the split? So the blister can form in a number of different levels. Broadly speaking, it can form in the intraepidermal level or subepidermal level. As the name suggests, intraepidermal means a split happens within the epidermis, whereas subepidermal split occurs at the level at the basement membrane zone or below. Within the intraepidermal split, this can be subcategorized into subcorneal or intracorneal, as well as spinous or malpighian layers, or suprabasilar, which means just above the basement membrane zone. On the right-hand side, you can see a fairly simplified version of the different layers of the skin and where each split occurs. The reason why understanding the level of split is important is because each level or each split level of the skin is associated with different molecules and different proteins that essentially acts as the signature for that level. And by understanding which level the split occurs, this will help narrow down the differential diagnosis, as different type of skin conditions cause a blister at different levels. As you can see here on the image on the right-hand side, there is a different differential diagnosis according to the split, whether it is subcorneal, intraepidermal, or subepidermal. In this video series, we will go through each of these differential diagnoses and how to make their diagnosis and how to do their workup and approach. Now, the reason why each level has its own differential diagnosis is because each level in the skin has its own molecular signature. It has different proteins. And to demonstrate this, here is a slightly more detailed diagram demonstrating the intraepidermal layer of the skin. On the right-hand side, we can see here some of the molecular proteins that is characteristic of the intraepidermal level. And these include the desmosomes. The desmosomes are essentially the junctional proteins that help the keratinocytes bind to each other and form the structure of the top layer of the skin. The desmosomes is characterized by two major transmembrane components. These include desmoglines, which is DSG, as well as desmocollins. There are also some other smaller proteins which bind to these, including placoglobin and desmoplakin. There are two major forms of desmoglines. There is DSG1 and DSG3, and these are the targets of antibodies present in one type of blistering disorder called pemphigus. Pemphigus vulgaris and pemphigus foliaceus are blistering disorders which contain antibodies which target these proteins in the top layer of the epidermis and intraepidermally, and that, as a result, causes a split level within the epidermis for this condition. In contrast, there is also subepidermal layer, and in the subepidermal zone, it also has its own characteristic set of molecules and proteins, which can act as targets for a number of other different blistering disorders, which is characterized by level split on the subepidermal level. The diagram on the right-hand side demonstrates a bit more detail in terms of the sublevels in this area, which includes the base layer keratinocytes, which is separated from the dermis or subepidermal zone via the lamina lucida and the lamina densa. Within these areas is a very complex set of different molecules which act as potential targets for a variety of different blistering disorders. Here is another diagram which demonstrates the same concept in one picture. As you can see here, on the left-hand side, we have a cross-sectional structure of the skin containing the epidermis, the basement membrane zone, the dermis, and the subcutis. Within the epidermis, if we zoom in, it has its own set of molecules which are characteristic of this area, including desmoglines. Within the basement membrane zone and the dermal epidermal junction, if you zoom in, you see a different set of proteins which characterize this area. One example is the bullous pemphigoid antigen proteins, such as BPAG1 and BPAG2. To re-emphasize, each level in the skin has its own molecular profile, and antibodies against these different molecules leads to different blistering diseases. Now, with that concept in mind, we can now understand what are the potential different target antigens for each blistering disorder, autoimmune blistering disorder. As already mentioned, pemphigus foliaceus targets desmoglein 1. Desmoglein 1 is one of the molecular proteins in the intraepidermal level. Other pemphigus also targets proteins in the intraepidermal level, and these include hepatiform pemphigus, which targets desmoglein 1, IgA pemphigus, which targets desmocollin, as well as desmoglein 1 or 3. There is pemphigus vulgaris, which targets desmoglein 3, whereas a subepidermal condition, such as epidermolysis bullosa acquisita, will target a deeper level layer protein, such as type 7 collagen, which is in the subepidermal layer. The table continues here, We have a number of other pemphigus disorders, including paraneoplastic pemphigus, which can target desmoglein 1 and 3 and desmoplakin 1 and 2. Bullous pemphigoid is a subepidermal blistering disorder, and it targets BPAG1 and BPAG2. Pemphigoid gestationis targets PPAG2. Dermatitis herpetiformis targets tissue transglutaminase. Linear IgA bullous dermatosis targets LABD97. There is cicatricial pemphigoid, or otherwise known as mucous membrane pemphigoid, and these target BPAG2 and plectin. And then there are a very rare form of blistering dermatoses, such as anti-P200 pemphigoid, which, as the name suggests, targets a target protein which is 200 kilodaltons in size. And how the target antigen antibodies cause a split is demonstrated in this diagram. And when you have an autoimmune blistering disorder, for whatever reason, your body will produce autoantibodies which target the junctions between the skin cells, or between the keratinocytes. And by targeting those protein junctions, they don't work as they usually do. And that causes separation of the skin cells, which then allow fluid to form in this space, which then creates a blister. And how high or how low the level of the blister in the skin will correspond to the areas in the skin where there is an issue with the junctional protein, and that corresponds to the protein that is affected, whether that's, for example, desmoglein proteins in the upper layer of the intraepidermis, or whether it targets something such as collagen type 7, which is deep in the subepidermal layer. The third question to consider is in terms of the clinical presentation, the morphology and the pattern of the lesions, because this will also further narrow down the differential diagnosis for your presentation. So the first option to consider is if the case presents with flaccid bullae with superficial erosions. If the bullae are flaccid, that suggests or indicates that the level of split is likely very high in the skin. And because it's very high in the skin, the blister is also very high in the skin, and that is easily disrupted by trauma, which means the roof of the blister can be easily peeled off, leaving crusting and erosions. So this indicates or suggests to us autoimmune as well as other conditions, blistering conditions, which target superficial proteins in the skin. So this includes pemphigus vulgaris, pemphigus foliaceus, drug-induced eruptions such as Stevens-Johnson syndrome and toxic epidermonecrolysis, as well as staphylococcal scalded skin syndrome. In contrast, if you have dense bullae, which are relatively intact despite trauma, that suggests to us that the blister formation is quite deep in the layer of the skin, and therefore is not as easily disrupted by trauma. And that indicates to us that the target protein is likely deeper in the skin, so possibly at the dermal epidermal junction or in the subepidermal layer. So if a case presents with tense bullae or hemorrhagic bullae, one must consider more deeper targeted blistering disorders, such as the subepidermal or dermal epidermal junction blistering disorders. And this includes bullous pemphigoid, mucous membrane pemphigoid, epidermolysis bullosa acquisita, bullous lupus erythematosus, as well as IgA bullous dermatosis. There is another subgroup that includes annular arrangement of the blisters. This is characteristic of linear IgA dermatosis, some cases of bullous pemphigoid, as well as some cases of Erythema multiforme. The images here demonstrate some classic appearances of linear IgA dermatoses. Next group includes grouped blisters. So blisters which cluster together over a region, such as over the elbows or over the buttocks, as shown here in these images. And that's quite characteristic of dermatitis herpetiformis or pemphigus herpetiformis. The next group is characterized by predominantly pustules, and there's a variety of dermatoses which are characterized by this, including candidiasis, subcorneal pustular dermatosis of IgA pemphigus, as well as erythema toxicum neonatorum, transient neonatal pustular melanosis, acropustulosis of infancy, as well as varicella. And finally, another group is annular arrangement of pustules, and this is quite characteristic of subcorneal pustular dermatosis, IgA pemphigus, as well as annular pustular psoriasis. We also should consider the distribution of the lesions in terms of whether it involves mucous membranes, such as the oral cavity. because there is only a small subgroup of blistering disorders which target this distribution. And that includes viral eruptions such as herpes simplex and herpes zoster, drug-induced eruptions including erythema multiforme major, Stevens-Johnson syndrome or toxic epidermal necrolysis spectrum, as well as pemphigus vulgaris, paraneoplastic pemphigus, and contact cheilitis. So think of these key differential diagnoses when you are presented with a case of a blistering eruption that involves mucous membrane surfaces such as the oral cavity. The fourth question in our approach to diagnosis is, what is the pattern of the cells histologically? So that's summarized by this table. In the blister, in the level of split, there may be the presence of eosinophils, and that can point you towards these specific set of differential diagnoses, including pemphigus vulgaris, pemphigus foliaceus, bullous pemphigoid, pemphigoid gestationis, mucous membrane pemphigoid, and linear IgA bullous dermatoses. Of course, there's a variety of other differential diagnoses, which is outside the autoimmune bullous disorder group, to consider, because these are also associated with eosinophils as well, such as drug eruptions, id reactions, Wells syndrome, insect bite reaction, so on and so forth. That's summarized here in this table, causes of eosinophilic spongiosis. So in summary, how do we approach a case presenting with blistering eruption, such as with vesicles or multiple bulla? So first of all, we need to consider a broad range of differentials, including autoimmune bullous disorders as well as non-autoimmune bullous disorders, such as infective, inflammatory, genetic, metabolic. If we don't keep an open mind when considering the differential diagnosis, we may miss the key diagnosis. The second step is to work out the level of split. So that is a combination of your clinical assessment as well as histological appearance. We need to work out whether it's an intraepidermal or subepidermal blister, because that will then help you narrow down your diagnosis. You can further narrow down your differentials based on the morphology and distribution of the lesions. And finally, support your diagnosis by testing such as target antibody testing, histological appearance, and immunofluorescence study, which confirms your differential diagnosis. Thank you for joining us today on this first video of our video series on autoimmune bullous disorders. I hope you've learned something useful about the approach that you can use in your clinical practice. I hope to see you at the next video.